Hi everyone, it is Dr. Lanice and I am an author, speaker, blogger, and I take care of sick babies for a living. I love to help tired, stressed out, frustrated moms who have preemies in the NICU. I like to help them better understand what's going on with their baby's illness, more effectively communicate with their NICU team, and most of all know that they can make it through the NICU journey and that we are here to help. They do not have to do it alone. So I am back with you today on Wednesday for another weekly Wednesday Facebook Live that I do right here on my Facebook page at 7 p.m. Eastern Standard Time. So I'm back this week and I want to talk to you about 5 things you should know when your preemie's gut is sick. All right, so let's get started. So the first thing that I want you to know is what is the most common GI or gastrointestinal emergency or gut emergency in preemies in the NICU, and that is necrotizing enterocolitis. So this is basically medical terms that basically mean there is inflammation or tissue damage or injury to your baby's intestines. And this can affect the small and large intestines. And this is an emergency for a preemie. Now, sometimes this can happen very rarely in full-term babies as well, but this is mainly something that happens in our preemie population for those babies who are less than 1,500 grams or sort of less than 3 pounds. So that's the first thing that I want you to know, because many things can be going on with the baby's gut. Sometimes there can be blockage in the intestines. Sometimes the babies are born and the intestines are not fully formed. Sometimes they're exposed and not covered. So different things can happen. But one of the most common emergencies that can happen for a preemie in the NICU is necrotizing enterocolitis. Okay, so the second thing that I want you to know is what is NEC, or necrotizing enterocolitis. What do I mean by this? So this happens basically when there's a lack of oxygen and not enough blood flow is going to the gut or to the intestines. And as a result, the wall of the intestines can become very weak, and it can lead to an inflammation, which leads to even more injury. And then after a while, the bacteria, right? We all normally have bacteria that's in the gut or in the intestines, but this bacteria in the preemie's gut can start to grow too much, basically have an overgrowth that leads to more damage and more injury to the tissue. And so in more severe cases, what can actually happen is that the wall of the intestines gets so weak that it can get a hole or a perforation. Basically, there's an opening inside of the intestines. And then this allows the bacteria that's in the gut to sort of get out inside into the abdominal cavity, and it can seep into the blood and lead to even more serious infection, right? So it can lead to a bloodstream infection. Sometimes this bacteria can even get into the spinal fluid, leading to a meningitis. And more importantly, when we have a break right in the wall in the intestines or an opening there, this becomes a surgical emergency. And so we also have to get the surgeons and the surgical doctors involved to sort of help the preemie out as well. So we know that, when babies are born early, many of the organs are not fully developed. So we know that as a preemie, the gut is not fully mature. They're not as able to sort of fight off infection. And as a result, that puts them at a very high risk to get this necrotizing enterocolitis or NEC. Now, one of the things that we do to try and prevent this is we give the babies breast milk, right? As much as possible, we always try to give breast milk, which is why when we talk to you moms, we say we want you to pump as much as you can and work with your lactation consultants, because our goal is always to give the babies breast milk first, just because we know that they're able to tolerate that better. So they're able to sort of digest breast milk better and absorb it into the gut better, and so it's more protective. So we know that babies who have formula are at a higher risk to get this NEC or to have this injury to their intestines. We also, in many NICUs, kind of have a feeding protocol of how we start to increase the amount of feeds or increase the amount of milk that the baby gets every day. And we do it in a slow process so that we get the baby up until what we call their full or goal volume feeds, which is the total amount that they need to get the calories that they need to grow and get the appropriate and right amount of nutrition. And the reason that we have this sort of protocol in place is that we know, it's been tested, that this is a safe amount that we can go up on the feeds to sort of be safe to allow the baby to digest and absorb it, get enough to grow and gain weight, but be able to tolerate it better. Because we know that if we go up too quickly, if we rapidly get the babies up on full feeds, we know that that is also a risk for them to get this NEC infection to the bowel as well. So basically it's just an inflammatory process that happens because you know what, sometimes, especially in our babies who are less than 1,500 grams, they're less than 3 pounds, they can be very sick in the beginning of life, right? So sometimes they need to have breathing tubes and they're requiring a lot of oxygen, and sometimes they might be on medications to help with their blood pressure and all these different types of things. And the way that, you know, the body works is it's going to send the blood to what we call the vital organs first, right? So it wants to protect and make sure that the heart is getting enough oxygen, and that the lungs are getting enough oxygen, and the brain, and all, you know, prioritizes the brain to make sure that this gets enough oxygen and that gets enough blood flow. So one of the areas or one of the organs that tends to be most compromised in that situation where babies aren't, you know, getting enough oxygen tends to be the gut, tends to be the intestines. So we know that those babies who are very sick and have all this going on, again, this puts them at a higher risk to get things like neck. So that's why we always, again, we try to give the breast milk, we try to go very slowly up on the feeds, we try to do all of those things to sort of protect the baby's bowel as much as we can. But unfortunately, you know, sometimes they will still get sick and they will still get neck. And it doesn't mean that just because your baby's on breast milk that they will never get neck. Sometimes we know that those babies can get necrotizing enterocolitis as well. We just know that it's much less likely to happen when the babies are on breast milk as opposed to when they're on formula. Okay, so number one, we first talked about what is the most common GI emergencies in preemies where their gut can get sick, and so we know that that's necrotizing enterocolitis. And then number two, we talked more about what that is, right? So that's when we have damage or injury to the walls of the intestine, we have overgrowth of the bacteria, and then it weakens it, and ultimately sometimes when the babies get very sick or the injury is very severe, you can get that opening or hole, perforation in the bowel wall that allows bacteria to get out into the rest of the body and can allow air to accumulate in the gut as well. So the third thing that I want to talk to you about is, so what are the signs? How do we know that your baby might be developing neck or that the gut might be sick? So one of the things that we notice that the nurses will tell us is that it seems like the belly might be a little bit bigger than normal. So one of the things that gets measured for the babies every day is what we call their abdominal girth, and that just basically lets us know how big is the belly. And it gives us an idea because as we're feeding the babies, we know that one of the signs that they might not be tolerating the feeds very well is if their belly starts getting bigger. So they might notice and they say, you know what, we know that it's gone up a couple centimeters, it's usually this much, you know, 30 centimeters, and we notice now that it's 32 centimeters, and so then we start to watch that baby closely. So that's one of the signs that we can see. The nurse also might tell us that the baby's starting to have vomiting, right? The baby's throwing up, and it might be dark in color, greenish, right? It sounds like bile. That's one of the things that can happen that we see in babies who are developing neck. And then we also might hear that the babies are having more residuals, right? So we know that when babies are this small, and when they're born early, they don't start eating by mouth right away. So what happens is, right, we have that feeding tube that I've talked before that goes in through the nose or goes in through the mouth and then down into the stomach. And so that's how the baby gets their feeds. And so after the feeding is done, right, babies sort of in the NICU is on an every 3-hour feeding schedule. So they'll get a feed every 3 hours. So sometimes we run their feeds over a little bit longer. Sometimes it's 30 minutes or up to an hour. And then, you know, they kind of have that break in between, that 2.5 hours or 2 hours to sort of digest and absorb that food. And so right before they begin to start the next feed, the nurse will sort of pull back on that feeding tube and see if there's anything left in the belly. So sometimes a sign that the baby might not be tolerating feeds very well is if we're getting back, you know, half of the feeding volume that we gave the baby. So if we're giving the baby 20 mLs or 20 cc's and we're getting back 10 of that or more, then that lets us know that the baby is not digesting or absorbing the milk very well. So that are some of the early signs that we can see. And then also babies can have other signs as well. They may just tell us, you know what, the baby seems a little bit more sleepy, not as active today. We might notice that the baby is having more drops in their heart rate, more drops in their oxygen level. If they're on breathing support, we might be needing to go up on their oxygen. We might have issues maintaining a good temperature. Sometimes they can be too cold where the temperature is too low, or they might, you know, start having, we're worried about fevers, very high temperatures. All these are different things that we can start to see that let us know, you know what, something's going on, this baby's not doing very well, we kind of need to look a little bit further. Another sign that we can also see is when the baby poops and has a diaper, we might see some blood in the stool. So that's, again, when we start to see that, or we see these increased residuals, or we notice that the vomit or the residuals are green, those are two key signs where we worry about neck. And so we'll definitely start looking a little bit more closely to sort of see what's going on. So then the fourth thing is, how do we treat it? How do we manage these babies? What do we do? So when we're worried that something is going on inside the intestines, inside the gut, we're going to do an x-ray. So we could take a picture and look and see what does the bowel look like. So sometimes we get the x-ray and it just lets us know that the intestines or the bowel looks a little bit swollen. Our word for that is dilated. It looks a little bit big. So we know that maybe the baby's not tolerating it very well, but we don't see some very specific signs, right? So in that case, we might just say, you know, we're going to pause the feedings. We're going to maybe put an IV in, put the baby on fluids, and kind of just watch and wait till the belly is less swollen and kind of see if the baby gets better. We're going to send off blood work, right? We're going to send off some blood for culture to look and see if there's any infection in the blood. We're going to look for a CBC, or, I've talked about this before. We look at our white blood cell count, right? And if that's very low or very high, we worry about infection. There's something called a CRP, right? We've talked about that too. That's a marker for infection. And when that's very high, we worry that, something's going on, that the baby might be very sick. Something else that we might see on x-ray that's another sort of telltale sign for neck is something called pneumatosis. Okay, so this is again another medical term that just basically means there's this bubbly or gas appearance in the wall in the intestines that normally shouldn't be there. And when we see that, we're like, okay, you know what, for sure, we know this baby has neck. And so the way that we treat that is we want to give the bowel a rest. We want to give it a break. So again, we're not going to feed that baby. We have the blood culture that's sent off, so we'll wait to see if there's any infection has spread to there. We will put the baby on antibiotics. And typically we'll treat with 3 antibiotics because in this case we want to make sure we cover the most common bacteria that could spread to the blood in other places, but also cover those specific types of bacteria that are in the gut as well. And so typically we'll treat maybe for a week or maybe 2 weeks because we want to make sure that we treat the infection that's there, and then we're going to continue to follow the x-rays and look to make sure that this pneumatosis that we saw is getting better and that it resolves. But there's sort of 2 ways that we can manage neck. One that we kind of say is just medical, where we kind of stop the feeds, we put the baby on TPN, we'll put in, we're not going to feed, so we're not using that feeding tube, but we put in a different type of tube that goes into the stomach, and we hook it up to suction. So it's sort of continuously removing air from the gut to sort of decrease the swelling, and it will remove any sort of fluid that's there as well to kind of help give the baby's belly a break. And then those are the ways that we can manage it. But sometimes if we see more serious signs of injury on the x-ray, again, right, I said when it's severe, sometimes you can have that hole or opening in the gut. And when we see that, that's a surgical emergency. So at that point, we need to get the surgeons or surgical doctors involved. So when we look there, we might just see that there's a whole bunch of air that we call free air all over the baby's belly. Or sometimes we might see air in one of the large veins over the liver. And that lets us know that this is a little bit more serious and this has progressed. And so that's when we sort of need to get our surgeon doctors involved. And at that point, then they'll assess the baby, and then we come up with a plan on what's the best thing to do. Sometimes, depending on how the baby is doing, they can just put something in that's called a drain. And that will help to allow fluid to be drained out and to help the air to be removed. And we kind of do the same process where we treat the baby with antibiotics and sort of continue to follow x-rays. Or sometimes it's much more serious where we have, that free air that's all over the belly, and we worry that maybe more of the intestines has been damaged. And so then the baby needs to go to the OR, where the surgeons will go in and they'll kind of look at the bowel, see where the tissue is that's infected, and then that needs to come out, right? Because when we have that severe damage or injury to the intestines, basically that tissue is dead or dies off. So that has to be removed. So what they'll go in is sometimes there's just a small area of the intestines that's infected, and sometimes it's a much larger area. So however much of that tissue is infected, the surgeons will take that out. If it's a small area, they might be able to put those 2 pieces of the intestines or the bowels back together. But sometimes it's so big, or there's so much inflammation and things going on, that they actually have to create something that's called an ostomy. And then basically they'll create a hole or opening, on the baby's belly or on the abdomen, and then they'll connect the part of the intestines to that wall, and then basically leave that opening there, leave those 2 ends of the intestines sort of separated and attach them to the bowel wall to give the intestines a break, to give it a rest, and then over time, over the next several weeks, then after the baby is doing better and the gut has rested and it's functioning again and we're able to feed the baby and they grow and get bigger, then the baby will go back to the OR and then they'll kind of put those parts of the intestines back together. So it's a kind of the two ways in which we can manage it. One, again, being just the medical, where we treat with antibiotics, giving the baby's bowel a rest and following with x-rays and following the electrolytes, which kind of lets us know how the infection is going and how the gut is doing. And the other one where we kind of need to have surgical procedures done and to have surgery involved. Okay, so that is number 4. That's sort of how we treat or manage it. And so then number 5, what does this mean for the long term for how your baby is going to do? So like I mentioned, this can be a very severe, serious infection, and actually things can progress very, very quickly. And unfortunately, it is life-threatening. So in some instances, unfortunately, some of these preemies don't survive it. But what we know is for all the preemies who do get affected by necrotizing enterocolitis or NEC, 30 to 40% of the time they'll have a very serious infection, or maybe they need to have surgery involved, or they get very, very sick. But that leaves a significant portion of the time, right, where we're just able to manage the baby kind of with that medical treatment, where they get 1 to 2 weeks of antibiotics, get some rest of the bowel, and then we're sort of able to start feeding them again, and they kind of get over that hump, and then, you know, it doesn't really impact their NICU stay as much. Or, you know, again, sometimes in those cases where they need to have surgery and they kind of need to have that ostomy in place, right, it does extend the NICU course because we have to give the bowel that time to rest and recover, and so it's a longer amount of time before we're able to feed the baby. And it does mean, you know, that your baby is ultimately going to have to go back and have another surgery to sort of have everything put back together. But again, it's also going to depend on how much of that bowel is infected or is sick, because if the surgeons have to take out large pieces of bowel, then that puts the baby at risk to get something that we call short gut syndrome, where basically they'll have issues sort of absorbing a lot of nutrients because of so much of the bowel being gone. And at that point, then we add in another consult to the team. It's not just the NICU doctors or the surgery doctors that are involved, but we will also consult the GI or gastrointestinal doctors as well, because they can give us a plan and a regimen that helps us, you know, how to best feed these babies and get them the nutrients that they need to grow in this kind of a special situation. And again, we also know, right, for our babies who end up being very, very sick, you know, they can have issues with their blood pressure. Again, they can need lots of product replacements. Their platelets can be low. They can be very anemic and need to get red blood cell transfusions and all those types of things. When those babies get very sick with that, all of those things can put them at a higher risk to get IVH, right, which is something we've talked about before, intraventricular hemorrhage, where they can have bleeding on the brain, right, because we know that all the blood vessels that supply the brain are not fully developed in preemies. So when they kind of go through this extensive process where they get NEC and they get very sick, they're at a higher risk to have this. And so when we do head ultrasounds, right, where there's that picture where they kind of take a look at the brain, where we look for bleeding, depending on how severe, if there's any bleeding or injury there, that can ultimately impact their development later on. So that kind of, you know, we can't predict what it will be for every baby, but we do know that 30 to 40% of the time it can be very severe. So all of these things, if they happen, this is what your NICU team is going to talk to you about. It can be very different for each baby. So as things are happening, they're going to continue to talk to you and sort of keep you informed about what's going on. But I did want to talk to you about this today because, again, this is one of the most common, you know, gut emergencies that we see in preemies. Once again, this is necrotizing enterocolitis, or NEC, right? So we talked about it being the most common emergency as the first thing you need to know. The second thing is, what is it, right? It's damage or injury to the tissue where you can have inflammation and infection there, and it weakens the wall, and sometimes it's so severe that it leads to what we call a perforation or a hole or opening in the bowel that becomes a surgical emergency. We talked about 3, what are some of the signs and things that we see in the baby, where we see the belly get bigger. Sometimes it can be red and tender. Babies are vomiting sometimes, or they have issues with their temperature. All these things where they're just letting us know that they're sick and that something's going on. 4, we talked about how do we treat it, how do we manage it. We give antibiotics. We do x-rays so that we can look and see what's going on inside the belly and whether or not our surgeons need to be involved. Sometimes surgeries are required. And then 5, what does it look like for the future is going to depend on how sick the baby is and how much of the bowel needs to be removed. So I hope that you found this helpful. Thank you for checking out this video. please share it with other friends and family that you know who may have preemies. Please follow me all across social media, and you can find me as at Dr. Lanice MD. That's the at symbol DRLAUNICEMD. Check me out every Wednesday on Facebook Live at 7 p.m. Eastern Standard Time, where I'm talking about all things preemie, all things baby, and all things NICU. If you are a preemie mom or a preemie dad out there, I have a freebie for you. So you want to go to www.drlanicemd.com/free audiobook. It's my free audiobook. I'm letting you know 10 things that you need to know before your preemie comes home. You don't want to miss this. This is going to help you get all this great information that you need to know so that you will be ready when your preemie is going to go home. So I will drop that link in the comment section on the video, so please check that out. For downloading the free audiobook, you will also get another bonus, which is going to be my 10 preemie tips for preemie moms and dads. So check that out. Thanks for watching this video, and I'll see you next time. Have a good evening.